Good morning, everybody, and also to those who are watching and listening online. I'm Liam Donaldson, the Chair of the Integrated Care Board for the North East and North Cumbria. And this is our public board meeting on 25th of November 2025. We have a number of apologies for absence, which I'll read out. Kelly Angus, Chief People Officer, Claire Riley, Chief Corporate Services Officer, Christopher Akers-Belcher, Healthwatch participant, and John Pearce, Local Authority Partner Member. In attendance is Michelle Evans, Director of Workforce. And before moving on to the agenda, I'd like to remind us that two of our members will be leaving the board at the end of December. Eileen Kaner, who's been one of our foundation independent non-executive directors, is leaving, and I'd like to put on record our gratitude for her work, not just in helping to get the board underway, but making very significant contributions in chairing a number of committees, and also her very, very important work in connecting the research and development agenda, especially related to public health, to the activities of the board as it moved into its new role. So thank you, Eileen, for all you've done for us, and we're going to greatly miss you. John Pearce isn't here today, but of course as partner member and Director of Children and Young People Services at Durham County Council, he's been an enormously valuable member of the board, and you'll remember recently some presentations he gave us about the role of children's services and how they're developing, and new legislation that's coming into play on those. So thank you very much to both. Declarations of interest. We've noted two here. One, our Medical Director Neil O'Brien is going to be presenting an item later on County Durham and Darlington Foundation Trust, and his wife works there, so that's technically a declaration of interest, but not something that interferes with his work on this particular area. And then under item 17, the strategic approach to clinical services framework, partner members from foundation trusts are impacted by the proposal, but they can remain in the meeting and take part in the decision making. And if there are any other declarations that aren't in your publicly recorded list of declarations that you want to raise? No, thank you. I check with the board secretary that we are quorate to proceed, and we are, thank you. Minutes of the previous meeting held on 30th of September. Are they an accurate record? Are there any inaccuracies you want to flag up? No, we approve those then as a true record. The action log and matters arising. Are there any items you'd like to check on progress or revisit in any way from that action log? No, thank you. And then considering the extent of the agenda, are there any items of business you wanted to add to the agenda? Any other business? No. Thank you. We pass then to our Chief Executive, Sam Allen, to give her regular Chief Executive's report.
Thank you, Chair, and good morning, colleagues. I'll take my report as read, but there's probably just a couple of areas that I'd just like to briefly focus on. So, first of all, colleagues will know that from an Integrated Care Board perspective, there have been a number of changes underway across England. So nationally, we've moved from 42 Integrated Care Boards to 26 Integrated Care Boards, with the theme there being that Integrated Care Boards generally getting bigger. Colleagues will know that due to our size already, that our geography and population that we're responsible for commissioning services for remains unchanged. But nonetheless, this series of changes set out by the Department of Health and Social Care to deliver the 10-year plan is a significant one. I think the key thing to note is that commissioning is viewed as having a clear future as part of delivery of the plan, and indeed in terms of the provision of healthcare services, there needs to be a function in the healthcare system that is responsible for both the planning of services and the buying of services. And indeed, as we make this transition as an integrated care board to become a strategic commissioner, there's been a number of documents published nationally, the most recent one being the Strategic Commissioning Framework, which I cover in my report. I think it would be fair to say that we do have some strategic commissioning muscle that exists already in our organisation. We have colleagues who have worked in commissioning over a number of years who will in fact even define their role as commissioners. Perhaps over the last 3 years, we've taken a more broader approach looking at the health of the population, and we've been, I think, perhaps less clear about the commissioning role and responsibilities. So as we go through this transition, the core function and purpose of each integrated care board will be to strategically commission for their population. We also need to maintain connection with places, but as a much smaller organisation, our ability to be represented at place will change. And to support this transition, we are expected to reduce our running costs. All ICBs are expected to reduce their running costs, as you know, by up to 50%. So it'll be a smaller, leaner organisation drawing on data. So whilst we've got skills and capabilities that exist already in the organisation, I still think we've got quite a significant amount of development to go on as a board, as an executive team, and also for our teams within the ICB. And in order to meet these new requirements, we've designed a whole new operating model, a way of working across the organisation. Board will know that we've been ready for some time to consult on that and move to the new structure, particularly given that these changes need to be in place by the next financial year. And I am pleased to say that more recently, the funding issue, of which has been preventing us from moving forward, has been resolved. So tomorrow we will launch our consultation for change in the organisation to transition to become a strategic commissioner. For us as an organisation, I think particularly given the scale of the changes that we've undertaken in previous years, we are looking at a headcount reduction in people terms of just over 90 posts. That is significant, and indeed when we publish our consultation document tomorrow to our staff, we'll be supporting our staff through these changes and also making available the option from tomorrow for staff to apply for voluntary redundancy. It remains our plan and aim to minimise the likelihood of compulsory redundancies through this process and achieve as much of the change as possible on a voluntary basis. Our transition committee has been meeting. We are confident that we've got clear financial plans in place at the moment in order to deliver on this. And whilst we won't be in a position to provide payment in lieu of notice, I therefore expect the change potentially to be, whilst we'll have got over most of the organisational change by the end of this financial year, we may well still have a small number of colleagues who continue to work into the organisation through the first half of next year. But from April, we will certainly be transitioning. As part of our plan, we also are doing work around development needs, looking at kind of skills and competencies in strategic commissioning. And I think particularly around the analytical aspects of this, particularly given we're a smaller organisation, we'll be drawing on data. I am delighted our new Director of Population Health commences in the organisation next month, and that's been a key appointment that we've proceeded with in spite of the changes, particularly given the prominence of that role with our responsibility as strategic commissioners. But in the future, I do envisage that given the size of the organisation, we will retract from place, and therefore over the summer months, in spite of stalling our organisational change, we've been convening partner members, particularly our local authority members and also our NHS Trust colleagues, to talk about the changing role of place leadership. And from a place leadership perspective, we really see our health and local government leaders really occupying that space at place level. And as a board, as part of this transition, we will early next year need to consider the role of our place committees going forward and seeking to delegate more resources and leadership responsibilities at that place level. And I think that's something I really welcome. I should also just add that we've been joined in those discussions by our two combined authorities, one in Tees, one in the North East, and we've continued a dialogue with our councils in Cumbria as well. Members of the board will be aware that there's a devolution bill at the moment under consideration. The role of strategic authorities in the future may well have greater role and remit with regard to healthcare, and therefore seeking to really strengthen our working relationship with our strategic authorities. And I'm delighted in the past month we've established our first joint post with the North East Combined Authority, and we're in discussion with our colleagues in Teesside and Cumbria as well, with a particular focus on our health and growth accelerator work, that real strong link between a thriving economy and health, which seems even more important in the week of the budget announcements this week as well. Why do those matter? And then particularly because of that role from a business perspective and an economic perspective. And therefore, Chair, I do just want to really conclude by saying job losses across health are significant at the moment. We are seeing reductions in workforce across our provider organisations, and also as we slim down our roles. As I said, we will always seek to ensure that we can do everything to mitigate any compulsory redundancies, but I can't rule that out at this particular point in time. And while some of the headlines, I think, from a public perspective, have talked about the role of bureaucrats and pen pushers across health sector, I think from our perspective in ICB, and certainly a message I've conveyed to all of our staff, is the work that they have done thus far has made a difference, and I think we can really demonstrate the difference that their work has made. Having said that, it is important that we implement the expectations that are required on us, and in doing so, seek through this process of transition to retain as much of that skills and expertise as we can, but also make sure that we're paying due regard to developing our capabilities as well. And Chair, I think probably, and I know we've touched on this as a board, we should dedicate some time in a development session to think about that transition, how we need to change as a board. And I know that we've looked at our own governance proposals, and we'll also be reducing in size as well. But just to make sure that we've really got a sharp focus on the core function of strategic commissioning as set out in the framework. Thank you.
Thank you very much, Sam. Comments and questions anyone would like to make? I must say, reflecting on the new role in strategic commissioning, it did strike me that if there was any ambiguity in the past about the commissioning role in our present organisation, I think it's much clearer now that in the future we'll be representing the needs of patients and the public very, very directly. So when we go to pass over our money to the providers of care, we're doing so on their behalf to ensure that they get the best possible service. And I think that frame of mind will be a very important one as we move forward, because as ever with any complex organisation like the ICS is, like the NHS is, there will be all sorts of arguments about whose role it is to do this and that. And provided we keep that at the forefront of our thinking, we can't really go wrong, I don't think. Sir Palihungi?
Thank you very much, Chair. Sam, may I ask very briefly, could you tell us how well we're progressing and how ready we are for the coming financial year in terms of our role as commissioners in the new world?
Yeah, thank you, Pally. I'll try and be brief. So one of the really positive developments is the expectation that as commissioners we put in place a medium-term plan, so planning over the next 5-year period. And you'll see one of the items we're going to be discussing today is our commissioning intentions and our proposed commissioning intentions, which we've shared in draft form with the system to signal the approach that we're taking. I think it would be fair to say we are very much still in the planning stages, so we will, by the sort of end of the second week in December, submit our first draft plan for that period of time. I think it would be probably fair to say we will be working on that well into the new year. We've got some more work to do. I know particularly around linking, for example, not just with our health and local government partners, but with our voluntary and community sector partners as well. We have at this current point in time only had 2 years worth of financial allocations given, but we do believe we'll get the 3rd year imminently, which will enable us to, at least for the next 3 years, a plan on I think a firmer footing, whereas you'll know that in recent years we've just had an annual financial allocation, so I think that's a really a positive step forward, but it does require some quite significant work in order to conclude that plan.
Thank you. If there are no other comments, I'll just check whether there's anything else. Oh, yes, Eileen Kaner, please.
Sorry, just to say, firstly, you've talked about the transition processes. As the outgoing chair of the Transition Committee, I want to commend everybody in the organisation who's been very diligent about trying to plan for the future. As this is a public board, I'll just make a comment for the benefit of the public to understand that this is a 3.5-year organisation, and about 18 months in, the organisation needed to remove 30% of its running costs, and very shortly after that to take another cut to its running costs. I'm really looking forward to the fact that you'll have a settlement of 2 and hopefully 3 years to be able to plan forward with a bit more certainty, because I think it's been an entirely difficult situation to be moving forward with such uncertainty and a constant series of changes. So I'm really looking forward to the future for you, but I really want to acknowledge the team and all the hard work they've done with a constantly changing and moving scenario, and I'm pleased you've got the ability now to move forward with voluntary redundancy, because I think that will help people have the certainty to plan for their futures.
Thank you. I'm aware that we have a question from the public from Keep Our North NHS Public North East, and we're going to provide a written response, but I just wondered if you wanted to add anything, Sam, to that.
Yeah, thank you, Chair. I'll read out the question. Will the North East North Cumbria Integrated Care Board ensure that these same principles are applied to the closure of wards and services across providers? And the principles being referred to are the principles set out in the National Strategic Commissioning Framework that my board paper includes. Gateshead Health NHS Trust recently made a decision to close Ward 23 at Queen Elizabeth Hospital without public consultation and without discussion with the Gateshead's Care, Health Overview and Wellbeing Scrutiny Committee. How will the North East North Cumbria ICB ensure transparency in decommissioning decisions so that patients, staff and the general public in the North East understand which services will stop and what the consequences of the cuts will be? Our response is all changes deemed a significant variation of services have to go through appropriate processes for approvals, which includes a formal consultation. There are some changes that are not deemed a significant variation and as such do not require formal consultation. Nonetheless, we're encouraging all trusts to work with us and ensure open and transparent decision making. As you know, the number of beds and wards are not and should not be the measure of success for a thriving NHS. Our focus must be on patient outcomes, and we will use our strategic commission responsibilities to do exactly that. And Chair, if I may just add, what we will do in addition to that response is include a summary on the way in which that change to services at the Queen Elizabeth Hospital was considered, and what assurance was in place that that was not deemed a significant variation of services for the board.
Okay, thank you. Does anybody want to add anything on that or pick anything up? Thank you very much then. So that concludes the Chief Executive's report. Thank you very much, Sam. Moving on then to item 9, which is an update to the Governance Handbook, and our Board Secretary, Deb Cornell, is going to cover that item.
Thank you, Chair. And so, if I may, I'll take both item 9.1 and 9.2 together because they are related. All ICBs have been asked by NHS England to do a review of their schemes of reservation and delegation, along with their remuneration committee terms of reference, to ensure that they have the appropriate delegation to enact the necessary arrangements with regards to redundancy approvals and the associated payments. So we've undertaken that review, and whilst there was already provision in the committee terms of reference to reflect that necessary delegation, the wording in the scheme of delegation wasn't quite as clear, so we're just proposing a minor amendment to the scheme to make that clear and to ensure it's consistent with the committee terms of reference. In relation to the committee's terms of reference, again, there's just some minor amendments needed to the membership to ensure that we can maintain quoracy going forward. So they are detailed, I think, in sections 4 and 5 in the attached terms of reference. Unfortunately, due to the timings of the meetings, we weren't able to take it to the Audit Committee first and also the Remuneration Committee first. However, a virtual approval has been sought from both of the committee chairs, along with the members, to bring it here today to seek that approval. So hopefully that is quite self-explanatory, but I'm happy to take any questions. Thank you, Chair.
Are there any questions? No, is everybody happy to move forward with that? Thank you very much. And then the next item, 10 on the agenda, Board Assurance Framework, is yours as well, Deb.
Yes. Again, thank you, Chair. So the purpose of the report is to bring an updated and refreshed Board Assurance Framework for Q2 to members. You will be familiar with this report, as I say, it's a regular report that we do bring. The report it details in section 3 the movements of the risks since the previous report, along with section 4 detailing those risks that have been added to the register. So with the exception of the Remuneration Committee, the framework is also reviewed by each committee along with the Corporate Risk Register. We've got the updated framework which is attached to Appendix 1 along with the supporting Corporate Risk Register at Appendix 2. The paper does also include an updated risk management strategy for approval today, which is at Appendix 3. We have undertaken an annual review of the strategy, and there were some minor amendments that we needed to reflect the approval of the board's the risk appetite by the board earlier this year, and those changes are in sections 4.2 and section 5. And just to bring to the board's attention, we will be doing a further review of the board assurance framework in light of our move to becoming a strategic commissioner. Obviously, we need to make sure that it remains fit for purpose and up to date, and we will bring in that updated framework to a future board meeting. So the board is asked to receive the report for assurance and to approve the updated risk management strategy. Thank you.
Are there any questions or comments for Deb? No. Are you happy to accept that report? Thank you very much indeed then. If we move on now to the items dealing with the individual board committees. Obviously you've had their full minutes, but there are certain points that we feel should be highlighted in this meeting specifically. So we're starting with the Executive Committee, Sam Allen.
Thank you, Chair. The report covers our most recent meetings, and I will take the report as read, Chair, in terms of the key decisions from the Executive Committee. Thank you.
And any points or clarifications you wanted here?
I think the only things I particularly highlight, whilst there were a number of decisions taken at the committee, firstly, the gluten-free prescribing. So this is an item that we discussed previously at board in terms of the future of the ICB continuing to support gluten-free prescriptions. And having looked at practice across the country, There are varying arrangements in place. Working with our patient and public involvement colleagues, we've undertaken quite a detailed survey, received extensive feedback from patients, carers and stakeholders, and we took that into close and careful consideration as part of our decision making, and the committee supported a recommendation to continue to make available gluten-free prescriptions to children and young people aged under 25, including those people with special educational needs and disabilities. So in terms of the change, we sought to safeguard those most at risk, reduce health inequalities, as well as address the challenge, some of the financial challenges that we're facing at the moment. We've also been in close liaison with some of the patient groups, particularly Celiac UK, on this approach. So the ICB is currently conducting a live consultation on that. That is open to both public and clinicians on the changes, and that consultation will close on the 12th of December. So certainly invite members of the public and those with interest to participate in that. And then just finally, we received an update on the Women's Health and Accelerator Plan. We will be discussing women's health at the board in the new year, so I won't cover this in any particular detail, but we received a report on the use of the one-stop shop model, mega clinics across the North East, North Cumbria NHS Foundation trusts, and that's really focusing around how we can reduce waiting times and improve the experience of people accessing those services, which has been incredibly positive actually, with some really significant improved outcomes. So we improved the changes, and we are drawing on funding through the Health and Growth Accelerator budget, particularly for women who have been on waiting lists, who are at risk of losing their employment, to be signposted into those mega clinic one-stop shops to have their needs met and support them, particularly to return to work.
Thank you, Sam. Are there any points anyone wants to raise about this, or questions, clarification? No, thank you. We move on now to the Quality and Safety Committee, and that's chaired by Sir Pally Hungin.
Thank you very much, Chair. So we have the confirmed minutes from the September meeting, and I'm going to present the highlights from our last meeting on the 13th of November. So I'd like to raise 4 points which are likely to be of interest to this public board. First of all, Martha's Rule. You may remember that this was a rule set out to enable relatives and friends of patients who are inpatients to be able to ask for a second opinion or to ask for additional help if they felt that things were not going quite as they should with their relative or their friend. The Martha's Rule was established in May 24, so it's been running for roughly a year and a half. It's now well established in all acute foundation trusts, 36 sites for us. Nationally, there have been over 6,000 escalation requests received from patients and relatives, and 39% of these were related to acute deterioration. 12% of these required escalation to an intensive care unit or transferred to some form of specialist or tertiary care, and 37% required treatment changes. As you can see here, the data we have available, which was provided very recently, relate to the region, and we had 822 calls logged during this period, which makes us the 4th highest in the country. Now, there are 2 ways of looking at this. One is that one way of looking at this is to say that the whole process has been very successful and that we are particularly good at enabling our relatives and friends to raise their concerns when they need to. And I think that that is certainly a very good thing. On the other hand, you might argue that looking at the national picture, considering the number of times that things have had to be escalated or changed, that this does indicate that perhaps we're not getting things right the first time. We don't have any information specific to our own ICB, although this may become available in the future. Of course, many of the points that are raised by relatives are not necessarily to do with quality and safety. but we will have more clearer data and information in the future as to how we're performing.
Would you mind if we just paused on this item, because I think there might be just a few points to make on it. I think you maybe remember the policy that was introduced. I was actually on the national planning panel for it, and then even before that I was conscious through my patient safety work around the world that failure to recognise that acutely ill patients are deteriorating, particularly children, leads to a substantial number of deaths each year. And the case that brought this to light was, of course, Martha Mills, the child who died. Her mother drew it to public attention initially, and then it was widely debated and became part of policy. But essentially, that clinical teams were not always listening to the concerns of parents or patient, who often, particularly with a child, will know the child very well. So it's remarkable that this has been implemented so quickly. But I guess I would wonder what the key percentages are there from a point of view of looking at the metrics in the future. It seems to me that the 12% requiring escalation to ITU or would mean that the parents' concern was justified and,
yes,
and hadn't been recognised by the clinical team. And then when after the escalation, 37% did require an amendment or a change to the treatment. So I just think as often the case with metrics, especially new ones, they don't always give you an immediate insight, and I don't know whether nationally they're intending to refine this, because I think there is a story there, but it's not absolutely clear how we should judge it, because essentially we would really want to know about the outcome and the extent to which the parents' intervention was necessary.
Yeah.
And so
you're absolutely right. We don't have the detailed information that would back up these numbers in terms of specifically what needed to be done and how crucial it was in these instances.
Yeah.
But I suspect that will be available in the coming year.
yeah. Okay, thank you. Please carry on now.
Secondly, an item that we've covered before about complaints received from patients or their relatives or their friends. Now we have a central unified system that's dealing with this. Initially, the system was based on locality setups. The system is working better now. We've had problems with personnel and also procedures, but I'm pleased to say that from the point of view of the Quality and Safety Committee, we are reassured and assured that the system is working and developing as effectively as it can be given the timescales. There's still quite a big backlog, but this is being covered effectively. It is a matter of some concern to us, particularly because we need to learn from things that don't go right and we need to effect them. Thirdly, the engagement involvement group, which is an important component of safety and quality, continues to report into us with their own concerns, ranging from problems with access to appropriate health care, not just medical, but also dental health care. And we would like to reiterate that the lessons we learn from them should be built into the commissioning process, so that we're not just meeting the metrics in terms of outcomes required from operations or number of operations, but also in terms of patients' own needs and requirements. I think I would just like to confirm that we will be providing this information to the Executive Board. And finally, health-acquired infections. You've heard me speak about these before. They tend to fluctuate, but at the moment we have a rising rate of healthcare-acquired infections. This has been a matter of some concern. There's been some action here. As an ICB, we have commissioned some work. We've had a number of meetings to discuss potential causes and how to evaluate and investigate remedial actions. And a very successful learning event was held just yesterday, which perhaps, Chair, you might want to expand on.
Thank you, Pally. Yes, I'd just like to comment on that, and I think Hilary Lloyd, our chief nurse, might want to add something. She convened an event yesterday at which we had many of the nurse directors and infectious disease experts from our foundation trusts present, with the aim, I think, of taking forward a big initiative on this to try and quickly reduce the burden of healthcare infection. But it was a very interesting meeting in that we had two experts from the World Health Organization that I've worked with before who are going to be helping with the initiative, but also two of the experts from the Newcastle Foundation Trust giving a very good analysis and indeed confirming what you said about the recent increases, and COVID obviously played a part in all of this. But I think one of the interesting things that I thought, one of the more important things that was said was that an infection in healthcare doesn't have the prominence as a patient safety event that many other things do. We had quite a debate in the meeting about why that should be, and why it should have a relatively low profile in management and board discussions, and the need really, I think, to try and raise the profile, because it is an area of potential harm for patients, which the evidence base is very, very clear on how it can be prevented, and the actions necessary to prevent it are very, very clear, but it doesn't seem to be being prioritized at the moment. So that was the main thing that I took away from it. But Hilary, you might say some more about what's intended by this initiative.
Yes, thank you, Chair. We certainly had a good afternoon reflecting and focusing on infection prevention control, and particularly looking at healthcare and health associated infections. It was a roundtable event. Just to give a bit of detail, we had around 25 people attending. They were all from across NENC, and we had some really excellent expert speakers, as the Chair said. Very much a collaborative approach to look at resetting and refocusing our approach to IPC and some of the challenges that we face around particularly the increase in infections that we know of. The plans to undertake initially we had three trusts. Three trusts have volunteered to be part of this, to really analyse the data, to visit the trusts to see how it works on the ground, and to do very much a diagnostic, to further really understand what the issues are in North East and North Cumbria. We plan to then formulate a plan of action, and I think in the day, I think we all learned something which was really, really helpful, and I just want to acknowledge through the really frank discussions that we had around the problems and the frustrations in the room over, I guess, lack of making improvements. However, there was significant engagement and motivation to create an environment to change collectively. So we will be reporting back once as we progress the work, but also once we've completed it.
And what I didn't say, but came out perhaps towards the end of the discussion, but very forcefully, is that we shouldn't be looking at this at hospitals in isolation, because the community I mentioned to this is really, really important. So another flag in the ground for integrated approaches, I think, to all of this. Thank you. Anybody else want to raise any comments about Pally's report? I mean, just to also, I think, to observe that we haven't tended to use complaints as a surveillance mechanism before. We do that with patient safety incidents, but I don't know whether you feel the quality of the data, aggregated data, is at the level that would allow us to do that.
Yeah, I think we are very much in a position to do that now, because all the complaints are categorized. So we know which specific box they're going to be, that they're in, and that provides a better overall picture in terms of potential system problems or regional or specifically some area problems, etc. So I think it's a question of watching this space.
Thank you. Right, we move on now to the Finance, Performance and Investment Committee, and that's Dr. Mike Smith's going to take us through that.
Thank you, Sir Liam. So you have in your agenda packs the detailed minutes from the September and October meetings, which we've discussed previously at board. So I'll provide in the slide a summary of the most recent November meeting. The main item that won't be otherwise discussed in this meeting was the Infrastructure Board update, where James Duncan, the Senior Responsible Officer for the Integrated Care System, provided an update on the work of the Infrastructure Board, which is reassuring that there's an awful lot going on in the capital world of trying to make sure that we make best use of resources and develop our estate as well as possible. There's the most reassuring report. The subsequent items on finance and performance will be dealt with by Jacqueline and David later in the agenda, so I won't go into those in any depth, but it was helpful to get an update on those.
Thank you. Any points anyone wants to raise on the work of that committee? No? Thank you very much then. And finally, the Audit Committee, David Stout.
Thank you very much, Chairman. We cover the routine agenda items, board assurance framework and risk management, and that was elsewhere on this agenda. We received a report covering a number of things around information governance, so that gave us a lot of assurance to the committee. We looked at the financial performance, internal audit, counter fraud, which is routine, and also we start kicking off the process again. Annually, we have to review, as a committee, the effectiveness of internal audit and external audit. So we have a process, 360-degree feedback, etc., etc. And we're just going to kick that off again. Just going back to internal audit, there's one thing I would say. In this current year, compared to previous years, we have a smaller internal audit programme, fewer days. That was for a number of reasons. One, because we need to save some money, because money is tight and we need to save cash. But secondly, when we're in a period of transition, it's difficult to support, staff-wise, difficult to support internal audit, to carry out lots of internal audits. So we're fine with that. But if internal audits are cancelled during the year, and we're in the middle of a transition, so that's probably quite likely really, then we need to replace them with an alternative internal audit. And the reason for that is at the end of the year, the head of internal audit has to give us an opinion, and we need them to cover a lot of coverage during the year so they can give a rounded, adequate opinion to the board. So we just need to be very mindful of that. It wasn't such an issue previously when we had a much bigger internal audit programme. It's an issue now. We just need to keep on top of it. Otherwise, fine.
Any points anyone's raised there? Any questions for David? No, thank you. We're moving on now to item 12, which is the annual report of the work on learning from the lives and deaths of people with learning disability and autism, and Hilary Lloyd, our Chief Nurse, is going to present that.
Thank you. The learning from the lives and deaths of people with learning disabilities and autistic people is our LEADER report. It's an annual report. It's a statutory requirement to provide assurance around the delivery of LEADER, including the numbers of reviews, the causes of death, and any learning and improvement actions undertaken across North East and North Cumbria. The paper has been presented and discussed in detail at the Quality and Safety Committee. So every death of a person with a learning disability or an autistic person is reviewed using a national review process. And during 2024, the ICB carried out LEADER reviews of 195 deaths. And of those, 192 were people with learning disability and 3 were reviews of autistic people. The findings indicated the most common reasons people died prematurely is largely unchanged than previous years. The highest reasons relate to either respiratory or cardiac problems. There have been some improvements made reported in the document, particularly the increased uptake of the annual health checks and flu and immunisation, which are helping to strengthen the lives of people with learning disability. But there's clearly very much more to do. We've got plans in place to expand our number of leader reviewers, just to ensure we remain compliant with the reviews in the national KPI framework. And this includes increasing the number of focused reviews, as you can see in the report. Now, every life matters, and these reviews are stories to help us understand what we do well and what we can do better. And as detailed in the detailed in Learning into Action report that we've also included, in future we will focus on health inequalities, on early interventions and on prevention programmes to embed the learning from the leader reviews. In particular, having campaigns around flu, around cancer screening and also suicide prevention. Ensuring the learning is shared. The three themes that come out in the report: accessibility, reasonable adjustments, and also listening and learning. So we will also work with people with a lived experience. We've got 2 groups across NENC that we work with closely in the Learning into Action group. Ensuring then the acute diamond standards, which are adjusted pathways, they are all embedded in it on our 8 acute trusts, and we just want to ensure that that remains sustained. And then working with learning delivery partnerships, offering the Oliver McGowan training across NENC. We know the uptake is variable, however, we have a working group to include all of the trusts to maximise local delivery. And then just finally to say there is a national review of LEADER. It's being led by NHS England. The outcomes are expected in 2025. We don't really have an indication of what those recommendations will be, but as soon as we know, we will look to put them in place. Thank you, Chair.
Thank you very much, Hilary. Levi, I knew you'd want to add something as well, so go ahead.
Thank you, Hilary, and thanks to Judith Thompson and the team. It's a really well-coordinated, comprehensive piece of work. I just wanted to note we received this report at the Mental Health, Learning Disability and Autism Subcommittee last week, the 21st of November, presented by Dr. Cathy Peterson, who again supports that work. And what we debated in the Mental Health, Learning Disability Committee was that it was an audience of people who have a lot of interest in this. And we considered whether there may be further forums, both internal within the Integrated Care Board, but also externally, who may benefit from receiving the report, particularly the lessons learned and what we may do further from a prevention perspective. So I know already the medical directors have offered to receive it at their future report. We've considered forums such as A&E delivery boards, etc., where we can raise the profile more of the preventative work. And secondly, along with Dave Gallagher, we're going to be doing a little bit of thinking of whether there's any contractual levers to embed, as you noted, the reasonable adjustments, easy read materials, access criteria, to help embed and hopefully manage that prevention agenda. So I just wanted to acknowledge it had been well received in that forum. Thank you.
Rajesh Nadkarni.
Thanks, Hilary. Lots of work going on around improving access, training, condition-specific work, and this has been happening for a few years now. Do we know as a system whether we're making any impact?
Thank you. I think the Learning Disability Network, led by Judith Thompson, as Levi has said, has made significant impact in the last few years. But as I've said in the report, there is still an awful lot more to do. I think in particular, if you pick out 1 or 2 of the items in the report, particularly around the positive behavioural support, has paid dividends in terms of support from families and carers and individuals as to how that has impacted on the ability to access services. And there was, in our Quality and Safety Committee, there was a member of staff who'd actually had a relative who'd accessed that, who reported that previously that their family member was just unable to access hospital services through fear, through lack of understanding and poor communication, but actually as a result of the positive behavioural support, they were able to access the care that they needed. So just one example of a few that are in the report there.
Tom Hall.
Yeah, thanks, Hilary. Mine was quite a specific question, really. Couldn't help but notice there seemed to be very few non-white mortalities, and I just didn't know if you had any kind of insight to that. It just seemed a bit unusual, that was all.
Yeah, and we acknowledge that in the report, and we're looking into that. We're trying to access through our networks, accessing into to various forums to ensure that actually we're capturing everyone we need to capture within that. So it may be that the numbers are the numbers, or actually we've got missing individuals in here that we want to look at. It is something we're exploring.
Are there any other points anyone wants to raise? Any other questions for Hilary? David Chandler.
Can I ask a question, Hilary? And sorry just to throw it at you. And I'd welcome your thoughts on it. So would it be fair to say, would the proof of the pudding be there in if we're seeing less people with learning disabilities die? And I say just die, because you could say die prematurely, but how do you capture that? But we know how many reviews we're doing. I just don't know what the trends might look like, or how easy it is to capture that sort of thing. Because part of me is thinking, if we come out outcomes focused, that's the key thing, is we don't want people to die prematurely who have got learning disabilities, and put things around that. So I'm just wondering if that's something we can capture going forward. And apologies to just throw that at you, but I'll just sit here with a cousin who's got severe learning disabilities, sort of worried about them.
Yes, so I'm not entirely sure what your specific question was, Dave, but I think the absolute key to this is to ensure that we avoid any premature deaths or any totally avoidable deaths from people with learning disabilities as a result of not being able to access the services that they need to get the treatment that we need. And we know that still far too many people are dying prematurely who don't need to. So that is absolutely the purpose of doing the leader reviews and actually learning from those and making sure that we then implement the learning. I think what's frustrating in the report is that there are no new themes coming out. They are the themes that they have always been. I guess one thing from that, it means that we need to continue to focus on those areas around respiratory, cardiac, diabetes, epilepsy. But there's also a question in there to see whether or not we are focusing in the right way if we're still seeing the same themes. I will be really interested to see what the national review tells us.
I can't see any more comments, requests to speak, so we'll leave it there, but very important work, and we look forward to hearing more about it. Hilary, thank you. We now move on to item 13, which concerns the County Durham and Darlington NHS Foundation Trust and the serious concerns that have been raised there about standards of care and wider management and governance of the trust. We considered this at the public board meeting of the Integrated Care Board on the 29th of July of this year, and at that point our medical director Neil O'Brien made a report where he told us about the independent report by the Royal College of Surgeons. And at that point, the investigation was into standards of care in breast surgery. But there were other concerns which needed to be investigated. And these have now been investigated by an independent investigator. And that report has only just been released into the public domain. So we haven't been able to include it in the papers of our board, but members of the public can see it having been released by the trust itself, who are due to consider it at their board tomorrow. But we did manage to circulate it to our board members in advance of this meeting. So we are going to extend our agenda discussion from a verbal report to a consideration of some of the findings in the independent report, bearing in mind that there will be a lot of follow-up work and further discussions required in this board arising from it. But if I, before passing to our Medical Director Neil O'Brien to talk about what was in the report, I'd like to ask our Chief Executive, Sam Allen, to talk about how this these concerns came to light and the process that was followed, and then potentially what further action is going to be needed in the future.
Thank you very much, Sir Liam. The first thing I want to say is I think this is an incredibly emotive subject. I think with my professional hat on as the Chief Executive of the Integrated Care Board, but also as a woman, I think, who has had to rely on NHS services, the very thought that any of our colleagues, our neighbours, our friends and our families who rely on these services, and indeed the women who've been impacted, those of whom have been identified already by the Trust, who are directly impacted by the results of the Royal College review, have been notified. But my thoughts are with them, I think, as this report finds its way into the public domain. I think anybody working in NHS services, and as I said, reliant on their local NHS services, will be concerned about the contents of this report. People who work in services need to be curious about the report, wherever they work, whatever their roles are, whether they're clinical or they're in a managerial role, will want to read this report, reflect, and ask themselves the questions, could this be happening where I work today? I think this is going to be a very significant report, not just for us locally in the North East and North Cumbria, but nationally as well. I think the report, Sir Liam, and we'll come on to this as a board, we've all read, carries a litany of failures. Failures of integrity, compassion, transparency, and of some of the basic fundamentals of good governance that we know are absolutely critical when it comes to delivering services. I think it would be fair to say for us as an Integrated Care Board, when we first became aware of the issues in breast services last year as a result of the Northern Cancer Alliance work, we demonstrated the curiosity to go and seek to understand what was behind these figures. And I think that has led to over a year's worth of work, of which I should note is ongoing, and the work is ongoing, to identify what the issues are. And that's what resulted in the Royal College of Surgeons review, which, as you've referenced, Liam, we've received at this report. Having said that, I think there were indications throughout our work with the Trust, whether it was the delays in the duty of candour, of which we challenged, and some of the practice that we identified through the report, and also behaviours that I'm sad to say, I think some aspects of this report do, I think, reflect some of what we found along the way. I do think we're still digesting the report, and I do think from a board perspective we want to have a fuller consideration of it in the new year. And whilst it certainly starts to explain the implications and why we've found ourselves in this position in relation to breast services, it does raise further questions with regard to the full range of clinical services that the Trust undertakes. And we will, as a Commissioner of Services, need to continue to work closely with the Trust to seek assurance that the areas identified, whether it be in relation to clinical practice, meeting certain standards, the issues around governance are addressed. I know the board, when they receive this report in public tomorrow, will also be asking those same questions and seeking those assurances. What I can share is that the Trust remains subject to an ongoing inspection from the Care Quality Commission, who've already signalled that they will be taking regulatory action. And the Trust, in its capacity as an NHS Foundation Trust, where it's licensed under Section 87 of the Health and Social Care Act, is subject also now to enforcement action by their regulator, their other regulator, which is NHS England, who are taking what they call Section 106 enforcement action against the trust, which will both legally require them to undertake certain steps, specifically with regard to quality and governance. I do think from the commissioning perspective, we'll want to reflect and ensure that we are taking not just the learning from this, but the relevant action. One step that we took earlier this year, where we identified the issues with regard to the use of limited liability partnerships and NHS Foundation Trust, is work to seek assurance from all of our NHS trust boards that we contract with at the moment through the National Standard contract. There is a very clear requirement in there that NHS Foundation Trust do need to seek the permission of their commissioners where they're establishing these limited liability partnerships. And we've also asked for assurance where they do exist that trust boards do have full oversight of them, both from the quality perspective as well as the financial perspective. I think just finally, Chair, if I just may do one final comment before I hand over to Neil, who I know will cover the report in more detail. One aspect that gets to the heart of this report is the issue of culture. It's really evident on reading the report that this is some of the issues people have been speaking up about within the organisation, and perhaps they hadn't been listened to, they hadn't been acted upon. When I reflect in our short time as an organisation, the just over 3.5 years that we've been in existence, we've had what I think are sort of 3 significant failures of quality and governance that we've considered in our local NHS trusts. Firstly, at the North East Ambulance Service, secondly, at Newcastle Hospitals, and now at County Durham and Darlington. I think this issue of closed cultures is something we're going to have to explore as a system and question, actually, is this a more systemic issue? And therefore, I do think, particularly with the learning that this report identifies, we are going to have some further work to do over the months ahead. There was also, of course, the issue that we inherited on becoming an ICB at Tees Esk and Wear Valley, that we've also touched on as a board, and issues around poor quality governance and leadership. So 4 significant issues over a relatively short period of time, but when you look at all of them, having perhaps been in place for many years historically. So I think as a system, we'll have to do a period of deep reflection that results in action on where we can, steps we need to take collectively to mitigate the likelihood or the risk of this continue to happen in the future.
Thank you, Sam. And I pass now to our Medical Director, Dr. Neil O'Brien, to take us through the main findings in the report.
Thank you, Chair. So for some time I've been updating the board now on the issues with County Durham and Darlington Foundation Trust and their breast services. The ICB has led the investigation which has exposed some of the issues that I will go into some detail on later on in my report. I'd just like again to express the concern that we have as an integrated care board, and I'll give some details at the end of my report for any members of the public who need to seek further information if they've been affected by some issues at County Durham and Darlington Foundation Trust breast services, and some contact details where they can gain further information. So just as a little bit of background and a reminder, I know Sam's already covered some of this. This goes back to May 2024. The Northern Cancer Alliance did some work which looked at some treatment variation, and when issues were highlighted to us that there were some significant treatment variations, we acted quickly to ensure that necessary safeguards were put in place to protect the public from any deviations from normal clinical practice whilst we investigated. We did commission a report from the Royal College of Surgeons, which did report out, and we reported that through our board in January, which confirmed that women were experiencing unnecessary or excessive surgery, that some of the clinical practice was outdated, and that there were problems in some of the leadership and the multidisciplinary team functioning within breast services in County Durham and Darlington. We immediately instigated an oversight group which I chair with NHS England to oversee the improvements that were to be made, and that work continues and has overseen some of the improvements that I will detail later on in the report. Currently, we are looking back at all of the cases to ensure that women have received the appropriate care, and if not, then those women have been recalled, and if there have been failings in the standard of care, then something called duty of candour has been enacted, which is a free and open and transparent conversation about where treatment has fallen short and what the NHS can do to try and remedy that. To date, we've the clinical reviewers, which are independent breast surgeons, radiologists and oncologists, have looked back through a number of the cases that were highlighted in the Northern Cancer Alliance report, and we're currently working through cases that for women who were operated on in 2023, and we're about half the way through that. I can report that within that group that have been reviewed so far, 44 women have suffered either moderate or severe harm, and duty of candour has been enacted with those, and those patients have been reviewed. Now, as a result of the work that we have done, we're also going to be further looking into the radiology practice, and just next week we have the Royal College of Radiologists coming into the Trust to do another detailed review to ensure that best standard of care for radiology investigation within the breast services is provided. Now, as a result of our investigation, it was clear that there were some significant concerns around clinical governance within breast services and widespread governance concerns as well. So as a result of this, the Trust commissioned an independent review of governance, which is the report that we've been referring to earlier, which is now available on the Trust website. The County Durham and Darlington Foundation Trust will be discussing that in their board tomorrow, and it does lay bare some quite significant issues, which I will detail some of the key points just now. It does show widespread failings in leadership and governance, which we take very, very seriously indeed, and we will ensure that the Trust make the necessary improvements so that we can maintain patient safety and public confidence. The report details aspects of patient harm and unsafe clinical practice within breast services. Women experienced avoidable harm. They experienced unnecessary surgeries, delayed diagnosis and missed treatment opportunities. There was lack of informed consent. Many patients were not told about all available treatment options, and that led to distress and loss of trust. There was emotional and physical impact experienced by women unnecessarily. The report details leadership and governance failures where warnings were ignored. There were repeated alerts from audits, surveys and external review that were not acted upon by executive leadership in the Trust. There was non-compliance with national standards. They weren't consistently followed within the Trust, and the mechanisms for picking up that non-compliance were felt lacking. The board was inactive in its both in its oversight and some of its committees to address some of the critical findings, which allowed some of these failings to persist. On the key points around workforce and consultant oversight, the Trust lost its training accreditation for breast surgeons some time ago, and that was mainly due to poor supervision and governance, and still there are not trainee breast surgeons within the unit to this date. There were a number of consultants who were appointed as locum consultants and were practising independently who were not on the GMC specialist register. Now, this can sometimes occur if, say, an overseas doctor or someone has a different training route, but it's usually for a short period of time whilst the doctor maintains, achieves the necessary evidence for inclusion on the specialist register. However, in County Durham and Darlington, the oversight of this was lacking. Some doctors were in post for years without proper oversight, and the Trust are rectifying that now and have rectified it. There was lack of support for some of the specialty doctors in training. They did not receive development funding or structured support as they should have. There are also failings detailed in the both contractual and operational oversight in contract management, and in that where the Trust subcontracted a lot of their breast cancer diagnostic work to limited liability partnerships, and the financial oversight and quality oversight of that was found lacking. There was a culture of fear and silence. Staff were afraid to raise concerns due to fear of retaliation, which led to people not speaking up and therefore delays in addressing some of the risks that have been outlined. There are examples of unprofessional behaviour, unprofessional conduct amongst some of the consultants undermined team cohesion and morale and culture. There was high staff turnover, particularly among some of the clinical nurse specialists. The Trust has faced increased regulatory oversight and scrutiny because of these failures, and it's also been detailed that the Trust's responsibility in enacting duty of candour was delayed, and that some incidents were underreported, which has further eroded trust. But as I've already reported, all of the women who have been affected by either moderate or severe harm have been informed now, and we are overseeing that the duty of candour process is enacted swiftly. All of these critical issues really do matter. They affect patient safety, they affect patient trust, staff well-being, and as an ICS, and along with NHS England, CQC and the Trust, we're absolutely committed to ensuring that the necessary improvements are made to restore public trust within County Durham and Darlington breast services. Moving forward, NHS England have confirmed that they have taken regulatory action along with CQC, and we are working with them very closely in a joint leadership arrangement to set up an oversight group which further enhances our response to this. We'll continue to support the Trust to diagnose any issues within the Trust that may affect other services, and we will swiftly seek to put them right. The Trust have an action plan put in place which covers leadership and corporate governance, clinical governance, culture, management of medical staff, financial governance, and issues specific to breast services. We will work as a system also to look at our configuration of breast services across the North East and North Cumbria. This was detailed in the Royal College of Surgeons report that it's not optimal at the minute, and we are currently looking at options, and as an ICB we will lead that process. I just finally want to express my concern and apology to any woman who has been affected by the care that they have received through County Durham and Darlington Breast Service, and the Trust have issued a full and unreserved apology for this on their website and also publicly. There is some contact information, and I'd just like to read it out. So there is a helpline telephone number for any woman who thinks that they may have been affected and have not already been contacted. That's 0191 333 2126, and there is also an email address which is available on the Trust website, and we can make it available on our website as well. Finally, there is significant media interest in this. There will be a documentary which is going to be aired on Friday by the BBC, which fully investigates the issues at County Durham and Darlington. Thank you, Chair.
Thank you, Neil. Well, that's a very thorough report on a report which is very clear and comprehensive. It's our first look at it, and obviously you've given a very thorough account of it, but nevertheless we've got things to consider further, and we'll be coming back to future board meetings to do that. Just ask one or two members of the board to comment first and then open it up more generally. Hilary Lloyd is our new chief nurse, as you know, and has the portfolio for quality. Hilary, any thoughts or reflections from you?
Thank you, Chair. I just want to echo comments already made around the concern that we have in reading this report, and also the concerns that we've had over the last year around the breast services. I think that there's a lot of lessons to learn here, and we need to ensure that we have acted quickly now and succinctly in ensuring that we have safe services across County Durham and Darlington. And I just want to echo my concerns and condolences to the women who've been affected by this.
Okay, thank you. And Dr. Mike Smith's a Durham GP. Any thoughts based on your experience of the services there?
Thanks, sorry. This is a damning report and really makes some very difficult reading in so many aspects, and I almost struggle to know where to draw on as a primary area. There's one section that cries out to me. I actually worked at the Trust as a junior doctor, a foundation doctor of 2010-2012, and at that time, I actually I spoke up about some practices I was concerned about. I reached out to a consultant colleague, and I raised these concerns about some of the training issues and patient safety. The consultant recommended that I forward these concerns, but anonymously, which I thought was a bit odd because I was quite happy to put my name to it. Subsequently, they then tried to figure out who had submitted the concerns and then tried to discredit the concerns. Ultimately, they didn't. They were founded and improvements were made. In this report, the same thing is described. There's examples where the executives have tried to identify people in this review process who are wanting to speak anonymously. People saying they don't want to go to HR because they can't, it's falling on deaf ears. That, I guess it stands out to me as a real concern, because that just suggests a bitter core in the organisation, and I just wonder how we can know where this is happening in our organisations, and how do we make sure it doesn't happen again, doesn't keep happening? How do we observe if they've improved? I struggle to answer these questions, but it's a concern.
Thank you. We will maybe pick those up later in the discussion. Turn to Sir Pally Hungan, the chair of the Quality and Safety Committee of the Board's Quality and
Thank
Safety.
you, Chair. The Quality and Safety Committee has been keeping pace with what's been happening over the last year and a half in particular. And we have been working with other senior colleagues within the ICB to ensure that the various reports coming through have been properly documented, and that the level of assurance that we've been offered, we've been evaluating that carefully. I think I would agree with what Mike has said, that sometimes there are informal signals that come from a very early stage regarding certain localities, trusts, whatever the situation might be. And it's often very difficult to codify them or to structuralize them in a way that one can move on to do something about it. Just as one might say that problems in one service may be indicative of problems in that particular trust or that locality. So I think we mustn't be too complacent. We have many other trusts and other organizations, healthcare organizations in our ICB region. And I'm sure everyone is a little anxious about what's happening within their own organization. So the real question that arises, which you've touched upon, is how do we begin to ensure that all organizations are compliant with the highest possible standards? And also, we must not forget that many health organizations are swimming against the tide in terms of recruitment, in terms of finding staff and personnel who fulfill all the governance requirements for appointments, and also in terms of meeting timely requests for management and treatment of people with potential cancer. So this is a more complex problem than might just seem at first sight.
Thank you very much. Lisa Taylor, you wanted to comment. Would you mind pulling the microphone in a bit, because it was a bit, that's it, yeah, weren't getting you very earlier on.
Thank you. I just wanted to ask Neil, if I was a woman living in County Durham or Darlington who needed to access the breast services, how could I be confident that I would be well looked after and supported adequately?
Thank you. So as I mentioned, as soon as issues were identified, we put in immediate mitigations to ensure that services from that date onwards were safe, were meeting acceptable standards. And over the last few months, there has been a lot of improvements within the Trust. There has been an appointment of new specialised medical staff that are most up to date with the new modern surgical techniques. There has been wraparound support from our screening centres within the North East and North Cumbria, and fantastic collaboration with clinicians. So specialists from other areas are coming into County Durham and Darlington to oversee internal improvements and also ensure that multidisciplinary team meetings are operating safely and following best practice. And we've also reduced the amount of activity that goes through County Durham and Darlington by diverting patients to other units so that they're not under too much pressure, and that we are assured that the care that's being delivered is safe. So I can confidently say now that if a woman is referred to County Durham and Darlington, then they will experience a better standard of care.
Rajesh Nadkarni.
Thanks. I mean, a very sad, distressing and difficult to read report. And I know in due course, as Sam made reference to, that we've had sort of 4 trusts where we had issues around culture, that we'll reflect ourselves to see how our systems can be a bit better to pick some of those things earlier. And I'm sure we'll come to a more comprehensive discussion about it in future boards. But in the meantime, when I have looked at the report, and it's just been out, I think yesterday or so, fundamentally, the issues kind of come around 3 domains. It's either patient experience and outcomes, how people have responded to national reviews of quality and incident issues, and finally, information about culture, whether it is about contractual issues, whether it is about losing trainees, speaking up, whatever that is. In my view, I think as an ICB, we should also request all the other provider organizations to reflect on this report and to see broadly around these 3 themes, how do their governance systems actually work, and are they really assured that things are triangulated, monitored, and escalated to the board in a timely manner. I probably think that is something we should consider now, while we consider ourselves how we develop our own quality insights and vigilance systems at a higher level to pick things in future. Thank you.
Thank you. Sarah Malik.
Thank you, Chair. Thank you, Chair, Sam and Neil, for your open and transparent update regarding the trust service issues identified. I echo the sentiments of colleagues of the significant concerns that the report raises, and my wholehearted support to those affected. I welcome Sam's plan for the ICB to lead and enable the change in working culture within the healthcare of our region, and I hope that we really start this by working with frontline clinicians before we work with the management teams. The ICB has already recognised the importance of women's health in our region, and we've invested in the women's health hubs as well as the women's health accelerator sites. But does this event highlight to us a more need to focus on women's health services? And I was just keen to understand what strategic governance assessments we will be undertaking, considering that now we've had several reports nationally on women's health and complications arising of that, such as maternity services as well. And will we be learning more from reading the signals within our own system?
I mean, as an ICB, we're absolutely committed to our strategy on women's health. But as this report outlines, the issues at County Durham and Darlington are wider than that. So I think as an exec, we've met and talked about this, and I think as a board, we've now committed to taking as much learning from this report as we possibly can. I think Rajesh's suggestion is very good. You know, all of our provider organisations reflecting on the content of this report. Yes, a lot of work still to do, and I think there'll be many more conversations within our board, I'm sure, relating to this, and we'll plan to bring a further update paper in the new year on that.
Eileen Kaner.
Thank you, Sir Liam. There's a lot to digest, and we've had the opportunity to read this report, which is in the public domain. I want to just point to something Sam said earlier in our board meeting about the fact that health and care organisations are undergoing significant change and reorganisation. It struck me when I was reading this report that in May 2024, the Executive Director of Nursing instructed the team to move forward with a large-scale duty of candour process, and 4 days later it was reversed, and primarily because there was an absence of redress and remedy process. It strikes me, I mean, these organisations, the Foundation Trust, predate our 3.5-year-old organisation, but to essentially reverse a decision about duty of candour on the basis that you don't have a process for redress and remedy, I think the report points out that this was a real missed opportunity to be able to, you know, move forward and actually deal with things in an appropriate way. So that just really jumped out at me, and I wanted to make a point about that.
Sir Pally wants to come back in again.
Yes, I wanted to make the point that has been raised before, which is that the provision of accurate data and the recognition of outlying data are very important in terms of picking up early problems. And I cannot emphasize hard enough the importance of that, and that it is incumbent upon all of us to examine numbers and figures that don't seem to be where they should be, and to start to look for the underlying problems as soon as we can. I think that's a role not just for our own Quality and Safety Committee, but for all Quality and Safety Committees in all healthcare organisations. That's an important lesson from this situation.
Just Ken.
Can I just come back to the comment about learning from these episodes and just reassure you and the board that as far as the foundation trusts are concerned, when we've had issues raised, Sam identified at the start the issues with NEAS, with TUV, with Newcastle Hospitals, and now with Durham. We will get the opportunity as a collaborative through the relevant chief executives to download a little bit of what's happened. We've had there already once with Durham in the last few weeks with the new chief executive. We'll have more of that. So we do get an opportunity to reflect on the lessons from these individual incidents and take them back into our own organisations. But as Sam rightly identified at the start, this is very much a journey about culture. And that will take a little bit of time. As each of these episodes happen, unfortunate though they are, we're learning something, excuse me, from every single one that we can take back into our organisation. So that bit of the process, I think, is working. How we test it is the next stage.
Okay, thank you. I've got just a couple of comments to make, and then I'll make sure that nobody else wants to say anything else. I think the point that our chief executive made is absolutely crucial. I think almost it's a bit of a strong way of putting it, but I think enough is enough almost with the NHS and public sector in general not to have tolerated these incidents, investigated them, tried to learn, and not go back to look at them systemically and fundamentally and particularly about culture. So I do think, looking across the whole country, there is a need to do that now. It struck me, and having seen a lot similar situations, not like on this scale, because this is in my view the worst I've encountered, but I have seen other situations over the years. And one of the things that strikes me, particularly with something that emerges from the professional arena initially, is how easy it would have been for this not to have come to light. How really easy. And you saw Mike's story about his junior doctor experience. And when I used to talk about this situation, I used to talk about the 3 R's in response to somebody that's raising an awkward truth that the organisation really doesn't want to admit to or get involved in or even think further about. The first R is reassurance. Don't worry, you know, we've got systems in place and so on. The second one is rebuttal. No, you've got it wrong. That's not really how it happened. Then the third R is ridicule. You look back to the Bristol Children's Heart Surgery crisis, scandal in the mid-1990s, and you remember that that was a long struggle by a young anaesthetist to try and bring all of that to light. And what happened to him was his career was virtually ruined, and he ended up in Australia having to flee the country. So I hope the freedom to speak up legislation, which is really powerful, has meant that that sort of situation would be in a minority. But I think in any situation like the County Durham and Darlington one, or anything else on maybe on a smaller scale, we should immediately test the resilience of the freedom to speak up process. And did it work? Did it fail? Was it used? Was it was it not activated, and so on. I think many lessons in here, but I think right at the heart of it, as Sam said, it's culture, organisational culture. So I don't know whether any final words by David Stout.
Yeah, just something else, and I would think this, wouldn't I, as chair of the audit committee. When I read the report, and I know we've just received it, and there's lots of work which you've talked about, etc. But if things around governance, so apart from breast, just general governance, have gone seriously wrong, I'm surprised that the governance arrangements within the trust, i.e. the audit committee, running a medium-term financial strategy, audit strategy, with annual audit plans, wouldn't, over the elapsed time we're talking about, have identified some of these problems. So I think there are silos of problems here, and we've talked about a number of them, but there's a whole collection of silos. And I'd be very interested in seeing, bearing in mind there is a regulator, NHS England, and there is a trust, separate statutory body. They need to sort it out. And we as an ICB, duty of care to patients, how all of that blends together to fix all of these silos in parallel, and then learn the lessons as to why this happened and how do we prevent it happening. So it's a complicated task we have in front of us, I think.
Do you have any final words, Sam, before we move on?
I think that's probably the key point in this. So I think we've got now clarity and evidence as to actually what has happened over the past sort of 15 years. And I think it's incumbent upon us, I think, if we are absolutely committed to our role, which is improving the health of our population, to make sure to work with the organisations whom we effectively buy services from, to support them inevitably with the cultural change, but just ensuring that we've got the safeguards in place. So I think for us as an ICB, as well as addressing all of the issues and supporting and working and continuing to work with County Durham and Darlington on the improvements they're making, we need to make sure we take the wider learning out across the system, and we've really got to get to the heart of why we've been in this position now. This will be the 4th time we've been in this position with significant quality and governance failures that have impacted patients. And so I think we'll be discussing this quite a bit more over the course of 2026.
Thank you. We'll move on now. The next agenda item is our regular report on performance, the delivery report. That's going to be given by Jacqueline Myers, Chief Strategy Officer.
Thank you, Chair. As in previous boards, I will draw out some of the key notable features of performance for the data published in October, which is the report before you. And also towards the end of the report, we've shared the headlines of the data that was published before we went through our committee cycle, but a few days ago in November. So, working my way through the report then, in relation to the standards that we focus on at the board for urgent and emergency care, during the September period, we did see a rallying of the 4-hour performance. Although we did not meet our plan, it was at 78.1% for the 4-hour standard against a plan of 80.3%. And unfortunately in October we've seen a fall back again for the first time, not delivering the national ask for the end of March, as we only delivered 77.2%. So we're starting to see pressure build in the urgent care system. In relation to the 12-hour waits in department, which obviously a key safety measure that we like to keep an eye on, reasonable performance in September, very close to our plan and much better than the national benchmark at just 4% of patients waiting, 4.1% patients waiting over 12 hours, but that has deteriorated also in October to 6%. We do benefit from weekly reports on infectious disease prevalence, and we do see in those reports that are flowing weekly that we've seen an early surge of flu in particular around 6 weeks earlier than last winter, and that's accounting for some of the pressure in the urgent emergency care system. We are working together through our strategic coordination centre and also by liaising with our providers to try and manage these pressures as best we can, and also get on and implement our winter plans, some of which won't be fully in action until December. So inevitably a bit of pressure in October and November where we see an early flu occurring. Moving, if I may, to the cancer performance, just wanted to preface remarks by saying that we do have some concerns about the performance year to date, both in relation to the 62-day urgent suspected cancer referral to treatment target performance, and also the faster diagnosis standard. That's the standard that expects patients on those pathways to get a diagnosis within 28 days. We are seeing some challenges there. We're not failing across the board, but we've got a bit of a turbulence in terms of some months meeting the standards, some not. In terms of the latest published data in relation to the 62-day target, 6 out of 8 of our providers did meet their plan for the month of September in the latest data. And in terms of the issues that are causing challenge, one of them is related to the previous item that a number of our trusts are providing mutual aid to County Durham and Darlington and taking extra breast patients both into their diagnostic pathways and into their treatment pathways, and that's particularly affecting North Tees trust in terms of their performance. And then the other significant issue is a quite steep deterioration in overall cancer performance across a number of tumour sites in the North Cumbria Trust. Their board recently took a recovery plan and approved that, and we're working very closely with that trust, but they have been escalated to Tier 1 by the national team in recognition of their poor performance, so a significant array of actions needing to be delivered there to get them back on track. In terms of faster diagnosis standard challenges, although the aforementioned movement of breast patients around the system is part of the story, it's not the whole story, Chair. We are seeing escalating numbers, so considerable growth in the number of patients entering these cancer pathways, which is putting a lot of pressure on the diagnostic pathways, and there's work to be done to make sure that we can expand capacity in those challenged pathways to meet demand. The skin pathway is one of the pathways that's under the most significant pressure, and when we discuss the commissioning intentions later, you'll see that we've got some plans to try and transform the way that we manage that pathway to improve performance. There is a deep dive planned into cancer performance and outcomes that I think you've been part of shaping, Chair, and we'll bring that back to a future board. Moving, if I may, then to the referral to treatment performance. We have seen some challenges here, as I reported last time in August, did rally in September and return to plan. So the headline target in terms of the percentage of the active waiting list that is sitting underneath 18 weeks is looking reasonable in relation to our plan. It's less good news, I'm afraid, in relation to the longest waits. So the board will recall that the national ask is that by the end of March, no more than 1% of the waiting list is sitting over 52 weeks or a year-long wait. And our own plan is more ambitious than that. We were aiming to get to 0.5%, and we were aiming to achieve the 1% by now, but we're sitting at 1.4%. And when we bear in mind that the overall waiting list is also larger than planned, that's a significant number of patients who are still waiting over a year for treatment. Again, we're working with the individual trusts who are challenged in this regard in terms of their recovery plans. We've also got a very active mutual aid committee that's supported by the Provider Collaborative that's seen over 800 patients move between providers to try and access earlier treatment. And so we're working to recover this position, but it is an area that I'm concerned about in terms of year-end delivery. Just to pick up the other couple of areas that are showing as flagging as red on the dashboard because they are consistently off track. You'll see that we are not delivering our own plan in relation to urgent dental appointments. The board has received the dental strategy, and there are a large number of actions in place to address this, not least the 23 urgent dental access centres that we've commissioned. And we are forecasting that this will begin to improve in coming months, but we're yet to see that flowing through into the report. We're still showing a very challenged position in relation to community waiting times, and particularly the patients waiting over 52 weeks. We did previously receive a deep dive into this issue, and the board will recall that there's a couple of big challenges here. One around the fact that we're continuing to identify new cohorts of patients that need to be reported under this data metric, and also that we have a big national provider included in the data, because this data set is about providers headquartered in the patch rather than patients who live here, and that is continuing to be a pressure. That being said, there are a number of local pathways that do need to improve, and we've got improvement plans in place with the providers concerned. So we are starting to see some improvement in our local position. Perhaps we'll bring a more granular report in relation to local patients at a future board. And lastly, you'll see that we're still flagging red in relation to the use of virtual ward. I think I reported at the last board that we think that metric is probably challenged by the fact that we don't seasonally adjust the availability of our virtual ward capacity to reflect when it's needed most during the winter season, and that's something we're going to look at in the next planning round. They're all the things I wanted to draw attention to, but as ever, I'm happy to take any questions. Thank you.
Any questions or comments for Jacqueline? Very thorough report, very excellent documentation you can look through with the new graphics and symbols in them. So nothing. Oh, Sarah Malik, sorry, didn't see your flag to begin with.
It's all right. Thank you, Chair. Thank you, Jacqueline, for a very comprehensive, very easy to read report. I just had a question around GP appointments. I noticed that the metrics had changed from a monthly number to a GP appointments per day number. And just looking at the number of appointments that are now available, because I know the terms primary care and GP have changed throughout the document several times, so I wasn't clear what that number referred to. Was it primarily GP appointments? And if so, extrapolating it over a month, that suggests that we're delivering 2.4 million appointments per month in general practice, which is nearly covering 75% of our population, which is exceptionally high. But obviously there is a push to see more. So I just wanted your reflections on that, if that's all right.
Yeah, thank you, Sarah. Firstly, on the move to a daily metric rather than a monthly metric, that's because we divined that quite a lot of the statistically significant variation was due to the number of working days in the month, and it was just skewing the data. So we thought it was plainer just to look at the daily, the average daily appointments. In terms of your latter question, it's general practice appointments. So the appointments that occur in general practice, they're not necessarily with the GP, I understand it, but they are general practice appointments. And as we've discussed previously when we did a deep dive into this in the board, there are types of activity now going on in general practice that aren't captured by this data set. For example, the online queries that I know many GP practices do many dozens of every day. So it's not a perfect metric in terms of capturing GP practice activity, and that's why periodically we dive into it in more detail. And I agree with your last point that when you actually think about if you're an average patient, how many appointments this means that you receive, although we know that there'll be huge variation around the mean, it really does show how core GP practice is to supporting our population and how readily they're able to access it on a daily basis and across the year.
Thank you. Dave Gallagher.
Thank you, Chair. And I probably just wanted to elaborate a little bit on the urgent dental access that Jacqueline reflected on. Looking at the report again last night, I just want to be clear with people, there's probably some contradictory information in there. So the manifesto asked, and indeed the planning guidance asked for a contribution to 700,000 additional urgent care appointments. We've put the UDACs in place. We've now, as Jacqueline says, we've now got 30 surgeries open in 23 sites. They've been running up fully from middle of November. The capacity that produced would be 109,000 against our 58,000 or so access being required. There are two issues when we're looking at the reporting that we need to reflect better in the report when we get to next time. One is there's a shift from appointment slots to occurrency of courses of treatment that were being measured on, and the two don't necessarily match, which is causing us to appear to be under-reporting. And the other is the fact that actually it's taken time to implement these UDACs, as it has for all ICVs, and therefore there's a lead-in time for it. So as of November, we're in a position where we providing annually 109,000 extra appointments for urgent care. We're having conversations with NHS England about how that's measured, because the measurement of it, not just for ourselves but for all ICBs, doesn't reflect the ask. So we'll probably bring a bit more detail in the next performance report when it comes back.
Thank you very much, David. Mike Smith.
Jacqueline, possibly a challenging question. I apologise in advance. At the infection control event yesterday, the main concern of the microbiologists seemed to be focused around CPE, carbapenemase producing Enterobacters. In the patient safety report, we've got incidents of E. coli. Does it mean those kinds of E. coli, or is it E. coli generally? Because the reason I ask is, given it was their main area of concern at the moment, whether we need to start having CPE or CPOs in the data, or whether that is the same data point we already have.
I don't know the answer to that, Mike, so I could either defer to our chief nurse or come back to you.
I think it's a really good question, and given the conversation we had yesterday about concerns around CPE, and well done for pronouncing it, is a really important one. What we report in this report is the national requirements, so that is, you know, MRSA, MSSA, it's the gram-negative organisms, but there isn't a national requirement currently to report CPE. If that is something we choose to do, I definitely think, given the conversation we had yesterday around CPE is here and we need to be acting on it, it's really useful if we absolutely know the numbers that we're dealing with and the trusts that are affected. So I think we need to look at how we can factor that in.
So the data is collected. We are the highest area by incidence as an ICB, so we can get the data. It's just, I'm just not sure whether that is the data point we have in the report.
No, this is the national report. This is national reporting.
Okay, thank you.
Did everybody understand that, or do we need a less technical explanation? Yeah, there's a lot of nodding of heads. So maybe we could do a little note round afterwards, just because it was a very important point raised. You're right to raise it, Mike, but it is quite technical. Okay, thank you. Are there any other points? I'm just trying to see whether I don't want to. Oh, yes, yeah. Deb's reminding me lunch is 12:30. I was actually thinking if we'd finished 10 minutes earlier than this, we could have fitted in the finance, but I don't want to squeeze the finance to an unreasonable. Well, let's have a go then. Let's see. You're very, very succinct and leave no room for doubt. So let's see if you can do it.
I was assuming you were going to ask, Chair, so I'm being prepared. So I will take the report as read, and I'll try and be concise. The report's the month 6 position of the ICB and the ICS. It also includes the underlying position of the ICB, which I think is important to note going into the financial planning round. From an ICS point of view, which is our main financial duty, we are currently reporting being slightly ahead of plan at £6 million, but that included our land sales. If you take that into account, we're actually effectively bang on plan. Now, the plan is a £25 million deficit. That's what we're currently recording. That's similar to month 4. Whilst it's stable, we do need to recover that in the second half of the financial year. And I'll come back to that in a second. I would share with the board that we looked at the month 7 position just the other day, and the month 7 position is relatively stable compared to the month 6 position. So we're not seeing a huge deterioration one way or the other. Or change rather. It's worth noting efficiency, because on efficiency, whilst we're delivering it as an ICS, our current efficiency is still a challenge in certain places. That's either because subsidiary didn't get over the line, and I won't go into any detail on that one, or because workforce numbers aren't reducing in line with financial plan. Some of that is non-recurrent, and hopefully most of it will be achieved going into next year, but some of it will actually require different plans. As Sam has noted, we did do a performance review on the 6th of October. That has led to a number of organisations identifying additional savings, including the ICB, and that has been overseen by the System Delivery Board. NHS England also did a number of mid-year reviews with both the ICS and with foundation trusts. That was at Chair and Chief Executive level, as you'd be aware, Chair. And that's also helped identify risk that we've got in the system to manage between now and the end of the year. Within the report, I state in there that the financial risk I felt in month 6 was around £63 million between now and the end of the year that we'd need to collectively manage. That had started to reduce and has been actively reducing following some of that work I discussed earlier on the 6th of October. That being said, one foundation trust, though, has, if you like, gone the other way, and we collectively have to manage that risk as well. But as we stand here at month 6 and indeed month 7, we're still reporting to NHS England that we forecast delivery of our break-even target at this moment in time. But as I say, it's not without risk. The ICB due to achieve its plan, that remains on track. I won't go into any detail because it's in the report, Chair, in terms of the pressures we're managing. They are similar to the month 4 position, so I won't go into any detail unless anybody wants to ask any questions. Last things I'd mention would be ICB restructuring costs. That we expect them to be around £12 million. We have funding from NHS England to support those costs, and you'll see within the report that we've got an underspend on running costs, which we'll use to contribute towards those costs as well. So basically, where we've had vacancies, that will contribute to the cost of redundancy. The capital remains on track, as it did at month 4, to achieve plan. Running costs, I expect fully to achieve plan as well, despite ICB restructuring costs. And then in getting into long-term financial planning, allocations have now been issued, but that's the next agenda item, so I will hold my fire until that one, Chair, if that's okay. I'd mentioned the underlying position of the ICB. You'll see in the report, it's a very technical exercise to actually pull together what is the underlying position, what do you include and what don't you include, and how far forward do you look. But in the report, you'll see that we've measured it at £20 million. That's been shared with NHS England. I think it's fair to say if I was to build in some of the full-year effect pressures that I know are coming down the line, that number would be higher. But of course, we'll have to just pick up that as part of our financial plan for next year, and I'll be referring to the need to identify additional efficiencies as part of that plan. That's all I was going to say, Chair, and hopefully that's been done within 5 minutes.
Very clear and very succinct. David Stout, Chair of our Audit Committee.
Thank you very much. But not particularly wearing that hat for this question. David, out of all, thanks very much for the report, very clear. The last slide, which is manpower, full-time equivalents, I know that's not your functional bag, but it makes interesting reading. I mean, we focus on trying to reduce the headcount, full-time equivalents, and the bottom line is we still have about 700 more than we had this time last year. So in fact, but maybe it would have been higher if action hadn't been taken. So I'm glass half full on this, really. But the part I want to flag up is, and you said that, there's lots of efficiencies to come in the second half of the year. And the graph shows the plan, and the current plan is to really major on that in the last 6 months, really get those full-time equivalents down. I wondered whether our information systems, what the lead time was, how long it takes to know whether that plan is actually working. Because if it doesn't work, then we probably won't make the savings, I suspect.
So to answer that question, showing there's two parts there, David. So first part in terms of the lag, the information we get is actually relatively quick that we get from our providers, and then we translate that into our pack and share that. So you're talking, a couple of weeks basically to put it together from the end of the month. So that's relatively rapid. You're right that the plan assumes reductions in workforce, but of course that's risky and it's challenging. If it was easy, we'd all done it by now and we'd be ahead of plan. I'm in touch with every single director of finance, and I talk with them on a very regular basis about where they think they're going to get to, and that's that risk figure I give. And then our job collectively is to say, well, if we think we might not deliver on the workforce, do we have a mitigation? Now, at this moment in time, I believe that we can, with a fair wind, with some workforce reduction and other savings, get over the line for year end. And that's why I'm saying I think we can still predict that. But it isn't without risk. I'm not saying we need all the workforce reductions. We do need to see workforce reducing. The other thing, lastly, I would probably share with you, David, is that following the 6th of October session, a number of organisations have redressed and looked again at their financial plan. A number of organisations are accelerating workforce plans and workforce reductions. And certainly focusing on agency, especially in terms of reducing that. So there's a lot happening, and we are conscious that we need to mitigate if it doesn't all come to plan to be able to deliver by year end. And I think we're in a pretty strong position compared to many other systems. That does give me some confidence as well.
Michelle, would you like to add something on the workforce point?
Yeah, so I suppose just to give some assurance around that, as David said, we are focusing on reducing the temporary workforce, so reducing agency, reducing bank usage, as well as the overtime usage of that. And there is a monthly workforce board which meets where all of the CPOs get together with Trudy Davies, who's the workforce lead from a chief executive perspective around that. And we do look at how we can continue to ensure that those workforce reductions do take place whilst ensuring that quality isn't impacted on as well. So they are discussed on a regular basis, and we do monitor that very closely.
Thank you very much for that, Chair. That's helpful.
Thank you, David. That's excellent, very clear. Thank you very much. So we break for lunch now and resume at 1 o'clock. So are we okay? Yeah. We're resuming the public board meeting of the North East and North Cumbria Integrated Care Board, 25th of November 2025. And we're now on to item 16, which is the item on finance and performance operational planning submission for 2026-27. And our Chief Strategy Officer, Jacqueline Myers, is going to start the discussion on that.
Thank you very much, Chair. Just for the board's benefit, there's a slide pack in the board papers, and we're going to take the presentation first before coming back to the commissioning intentions paper, because I think it makes more sense to set the context before we go in the detail, if that's all right. So we've got a presentation for you, which is in the pack, but we'll also put it up on the screen, which is a two-hander between myself and my colleague Dave. So I'll take you through the main tenets of the planning process and what we know about the requirements in terms of the guidance that's been published, and then Dave will take you through the financial position before we come back to the commissioning intentions. So, as has been mentioned by the Chief Exec earlier in her report, we've commenced an NHS medium-term planning process, which is described as covering a 5-year period through to 2030-31. Although, as you'll see as I get into the detail, actually, the kind of level of granularity and kind of confirmed requirements is much clearer in the early years of that 5-year plan than it is in the outer years, which I think is inevitable, but we'll sort of draw that out for you as we describe what the requirements are. We had the medium-term planning framework published on the 21st of October, and we've moved into the first part of the planning. I think it's fair to say that there still are some elements of the guidance and the detail that we await. And as Dave will describe, just last week we got more confirmed detail on the financial allocation, so we're still working through that. So some of the templates that are required and some of the technical definitions are still to come, but we certainly have enough to get going, as it were, and we've commenced our ICB and ICS planning process in line with our own framework and our kind of well-developed ways of working with our wider system partners. As mentioned on the slide, we've got a first submission expected. It's now confirmed to be at noon on the 17th of December, and then there's a further submission confirmed now, even since these slides were developed, in early February. One of the notable changes in this year's planning round is that our colleagues at NHS England are taking a more direct and involved role in the planning with providers, particularly with a smaller group of our Foundation Trust providers who've been deemed as challenged and requiring additional support, and I'll say a little bit more about that in the moment. And also the planning submissions this time from the Provider Trust will go direct to NHS England, albeit we're working closely with them, and in the guidance as a requirement for us as commissioners to triangulate our plans with those of the providers to make sure that they make sense in relation to each other. So just moving on to that issue of challenged providers, there's been a process that's been gone through looking at an array of metrics, financial, workforce, quality and performance to determine which providers across NHS England require additional support. And there are 3 in our North East and North Cumbria patch that have been deemed to require that support. They are the Newcastle upon Tyne Hospital, Foundation Trust, North Cumbria Integrated Care and County Durham and Darlington. And so just this past week, we've had the first of those meetings to work out how we'll support those trusts. Really just exploratory conversations in the first round. I think it will be after we've got those first draft submissions that we'll really have a sense of how that broader support will kick in. So really the meetings are focusing on process, and the ICBs are participating in those meetings alongside our NHS England colleagues. On the next slide, I just thought I would draw out some of the key delivery priorities that have been set out for the first 3 years of the planning round. The key focus, it's fair to say, is on those constitutional waiting times targets that have existed for a fair old period now. But really since COVID, and in the case of cancer for a couple of years pre-COVID, have not been delivered nationally. So the headline is that the expectation of this 3-year period is that we will return to the delivery of the standards as set out in the Constitution. So that would be 92% of patients on the active waiting list being under 18 weeks, getting back to 85% against the 62-day standard, and no more than 1% of patients who are waiting for a diagnostic test to wait more than 6 weeks. On the urgent emergency care standard, the standard that's been asked for to be returned to within the 3 years is 85%, and a full return to the category 2 18-minute response time. All the measures that have been included for that 3-year period are that within primary care, 90% of urgent cases should be seen on the same day. Community and dental have got a new standard of 80% of activity within 18 weeks, as well as we mentioned just before the lunch break, that requirement in the first year to do that 700,000 additional urgent dental appointments. In the realm of mental health, learning disabilities and autism, there are a number of asks in terms of capacity and the further reduction of out-of-area placements. Although there are not so many hard measures, it's more about improvement from base. One specific absolute measure is a 10% annual reduction in inpatient care for patients who have a learning disability and or autism. And in addition, there are targets around reducing banking agency. Really for the benefit of the board in the pack, and for members of the public who want to see it, this slide just tabulates all of the specific deliverables that are required in the first year, the coming year, 26-27. I think the first thing to note is just how many there still are, given the headline was a kind of reduced number of asks. But you can see that there are some significant challenges here. I'll just draw a few out for the benefit of the board. Each individual provider trust in the acute sector, so we have 8 in our patch, will be asked to do a minimum 7% further improvement in their 18-week performance, or achieve 65%, whichever is greater. That's a really significant further step up towards getting back to 92%. And then in the cancer realm, we've got a step up to 85% for the cancer performance. Again, a really significant step up. So some real challenges in here to be achieved in the first year. I won't go through all of the detail, Chair, because of time. Just to say a little bit more about the facets of the planning round, because as I mentioned at the top here, it's a 5-year planning round. I think for various reasons in the way that it's been rolled out, the order might not be as logical as we might hope. The development of a 5-year strategic plan is a later requirement, first cut, going in, the first being submitted in February, and then there's a requirement for a comprehensive needs assessment that has to be completed by the end of March. So I think what we're probably seeing is a new regime and a sort of gradual introduction of it in the first year before we get into a cycle. And I think some of that, to be fair, may be in deference to the level of change that's been experienced in the ICB sector during this planning round. But nonetheless, we have a requirement to develop that robust 5-year strategic plan during this planning round, as well as 3-year numerical returns for workforce, finance and performance. And as usual, there'll be board assurance statements expected so that we can demonstrate that we've got robust oversight and endorsement of the plans that we submit. I just mentioned that the ICB and trust submissions are now separate, and that means that we won't be bringing to the board a collated version of all of the plans for all of the providers across the ICS. We will, however, likely be bringing a statement of triangulation to demonstrate that we've reviewed those plans and that we're content that our own plan is sensible in the context of the plans of our providers. The triangulation template hasn't been released yet, so we're just waiting for further detail of exactly how that will play out. The next slide gives you the planning timeline, as you can see there. And at the bottom of the slide, sorry, it's not very clear, the full submission deadline is the 12th of February, a noon deadline, and that incorporates 3-year finance plans, 4 years for capital, 3-year workforce plans, 3-year activity and performance plans, and an integrated medium-term template with all of the board assurance statements, as well as 5-year plans and 3-year ambulance plans. and the anticipation is that plans will start to get signed off by the 12th of March. The aim that organisations will be in a position to have a signed off plan for full implementation from the 1st of April. I won't dwell on this slide, but just to set out the ICB approach to planning, we did a lot of work that the board looked at and endorsed our revised planning framework this time last year, and we're really just building on that process to continue to aim to have a fully integrated approach across quality, performance, finance, and working together as a team. And I'll be pleased to bring forward the proposed commissioning intentions a bit later in the discussion. We are working to thoroughly understand our baseline and develop the first set of draft plans in the next couple of weeks. And we've got plans to discuss those with the relevant committees before submission. And in prep for this very tight timeline, in case I haven't drawn it out, obviously we're less than 4 weeks from first submission, and as I mentioned, the allocations landed only last week. We're working closely with our trust to receive flash reports to understand how the plan is going and how close we are to the ball. I think it will be fair to say that really intense work will need to take place between draft submission and final submission to really get to where we need to get to, given the very challenging timelines we have been set. And then just briefly in terms of the approach to workforce, and in fact my colleague Michelle commented on some of this just earlier, so I won't reprise it all, but we continue to focus very closely on the workforce, obviously as the main resource that we have in the system and the main driver of cost, but also of delivery and quality. We've done some mid-year workforce planning submissions, and we're working with providers to get underneath those and understand any significant variance to plan. We mentioned the Workforce Board having oversight to it, and we have workforce leads in our weekly planning processes to make sure that we're trying as we go to, as far as possible, keep a close triangulation between activity, finance and workforce plans. And I'll hand over now to David to take through the financial slides. Thank you.
Sorry. Thank you, Jacqueline. So, is it that one? There we go. So I've just got a few slides where I'll take members through the financial planning, the allocations, and what this means for the ICB and the wider system. So as Jacqueline mentioned, just last week we had allocations published and the technical guidance and the requirement to submit a draft plan by the 17th of December. We've got 2-year allocations, the third year will follow in due course. The final plan will include the 3 years, as Jacqueline said. ICB allocation growth is 2.7%. That's the national average figure. The ICB is no longer deemed to be overfunded, so the good news, we receive that average funding now with no convergence adjustment. The cost uplift factor, so that's the, if you like, the inflation on contracts, will be a net figure of 0.03%, so in essence flat cash. There's an uplift for inflation, and then an assumed efficiency target of 2% gets you to a net position there. So the remainder of that 2.7% growth uplift is being split with a guide to us for how much should be allocated to various sectors for various things. And in general, the narrative we have from NHS England is that they have nationally calculated what an ICB is requiring to spend to achieve all the targets and requirements that Jacqueline was alluding to earlier, or at least the vast majority of those. There'll be other things we'll be expected to do as well. NHS England have been stating clearly that they want to be much more committed to allocating resources on a much more fair shares basis and move away from the current regime that they inherited. And you can see that in elective recovery funding. So the amount issued to the ICB is different to previous year, and we can see that that's now been allocated more on a, what I'd call a population basis. So our allocation for elective recovery, for example, increases by about £25 million for fair share, and then there's another £50 million for 26-27 requirements. Deficit support funding is a big change, though, because we're moving to a more fair share allocation regime. That means deficit support funding is going to be phased out. We currently receive £33 million. That's been phased out over 3 years. The vast majority of that coming out in year 1 in 26-27, and that will create significant challenges for those that receive it, which is North Cumbria, Gateshead and South Tees. So they will find it very challenging to achieve what is expected by NHS England. There's all NHS organisations will break even, and that all organisations will still have regard to system working. That duty still exists in statute. The other thing I'd mention there is the contract rebasing exercise. That's an extremely important one to mention. Through the summer, every organisation went through a process of, if you like, recosting or attempting to recost their contract and compare it to what they would get under, if you like, PBR type rules. Mental health and community has been parked for now, but on the Acute Foundation Trust, even though the work, I would say, was done to best endeavours, I wouldn't say the work was done perfectly, and the providers and commissioners agreed the numbers. We have a better understanding of the cost of providing services, but what NHS England have said, basically that gap between what an ICB is paying and what an organisation should be receiving should be closed relatively quickly. And the pace of change is a 2.5% per annum of contract value. That 2.5% might not sound like a big number, but I assure you when you work out the maths, it equates to tens of millions of pounds for organisations per annum. So that is going to be a real challenge for us to work through as a system, especially those who are deemed to be overfunded. This next slide just takes you through the principles and the approaches that we've agreed either internally or externally. So we have agreed that we will continue to work on a principles-based approach. We had that in place historically. Those principles around things like putting patients at the heart of everything we do, but also recognising that the money's the money. And Sir Jim Mackey, the Chief Executive of NHS England, has been very clear to make sure that every organisation is aware we must live within our resources, so that principle's in there. But also, the Director of Finance for NHS England is very clear that system working needs to continue, and we've recognised we're very much in a transition year this year. And given the amount of time we've got to develop a draft plan and submit and then get on with delivery is so limited, really, that we've agreed to keep things simple, keep them pragmatic, and get on with this at pace. And that's been agreed across the ICS. From an ICB point of view, some of our planning assumptions that I'll just bring to your attention. We recognise it's really important our financial strategy is aligned to commissioning intentions. Okay, otherwise, what's the point of doing them? So that's really critical. The growth assumptions that I talked before, that NHS England have issued and sort of said that's what we think you need to allocate. We intend at the moment to follow them, subject to affordability. There is a little bit parked in the allocation for what they call left shift. It's not a huge sum of money, but it's important that we protect that and work with providers to make sure that's allocated alongside commissioning intentions and in true spirit of what is regarded as left shift, subject to affordability, and that's going to be a key problem for us as we go through the planning round. And just to share, ERF funding, I talked about, that extra money will be allocated on a fair share basis. The last slide I just share with you, well, the second last one, is just to share with you that when we run the draft numbers and just get a feel for what this means from the ICB perspective, as a strategic commissioner, the level of efficiency that we anticipate we will need to find to deliver a plan over the next 2 years. And you can see it will feel relatively similar to the level of efficiency plans and savings we had to make in the first financial year, so 25-26. So, for example, we've committed to making service reform savings of £30 million per annum, and we will need to make continuous savings in all age continuing care and prescribing. The prescribing one will be especially challenging this year, and that's because the uplift we've got for NHS England is a net uplift in the calculations. So basically, they've already accounted for some of the price savings. So that's going to be, it's going to make Ewan's job basically in prescribing even more difficult in terms of having a plan that delivers that task. So we'll have to work closely with him to make sure it's an achievable one. In terms of next steps, obviously it's important that when we put the plan in on the 17th of December, even though it's a draft plan, and it's important that that plan links to all other organisations' plans, and it effectively, 1 + 1 = 2 when they add the plans together. We don't need to obviously work with the board to make sure that the board is oversighted about what's going in. Board aren't expected to approve the plan. So what we intend to do to make sure we hit these deadlines is issue draft mandates this week for providers, especially NHS providers. We'll have a meeting with the Finance Performance Investment Committee on the 3rd of December. We'll be able to flesh out a bit more the detail of the plan itself. We've got a non-exec meeting on the 15th of December. Again, we can say this is what we intend to submit and this is what it means, and the draft plan or the draft plans going in on the 17th of December. So hopefully that's helpful, Chair, just to give you an overview of the financial aspects of the plan.
We have a choice now, Chair. We can go straight on and share the commissioning intention paper and then take the questions all together. And would you like to do that? Okay. So the third part of what we want to present to you today is the draft commissioning intentions that we're presenting to the board for approval. I just want to make a few remarks. I know you will all have seen the paper, and I think we've set the context fairly clearly in the presentation. There is a requirement to publish commissioning intentions in the guidance, by the way, and I think we all understand that if commissioning intentions are going to be useful, they need to come at the very start of the planning process so they can inform things going forward. But the nature of that means that we're developing them before we've got all of the information that we might ideally require. I think, though, as we get into a cycle on commissioning intentions, we will, in the context, hopefully, of rolling allocations with more than a 1-year time horizon, be able to develop them even earlier in the year in future. I think we've had a useful and engaging process given the time straits available in terms of how we develop this. We work with our existing infrastructure, so our teams, our programmes and our networks, many of which include wider partners from sectors, including the voluntary community sector. And we have over 63 submissions that informed the document that sits before you now. Clearly, we also were informed by our extant strategy, Better Health and Wellbeing for All, and indeed by the national planning guidance, as you would expect. What we aim for in these commissioning intentions is a high level of specificity. I think more developmental pieces of work that describe a direction of travel, some of which there is a lot of material for in the submissions received, sit more comfortably in the 5-year plan. So the commission intentions are purposefully relatively specific and narrow in scope, and about what they are, the very specific things are that we will aim to do in the next financial year. Because of the financial context, which I think has been really clearly articulated, as you would expect within the commission intentions, there's a real focus on reshaping services, redesigning them, recommissioning them, and in some cases decommissioning services, rather than it being a list of investment choices, because that's not the context that we're operating on, as you would expect. As I mentioned, the commission intentions have been reviewed and approved by the exec committee, and so we're recommending them for approval by the board chair. But I'm obviously happy to take any questions. It is a very dense document, I recognise that, so we're happy to take any questions either on the wider planning process or indeed on the commissioning intentions, but we're recommending that the latter is for approval by the board. Thanks.
Okay, we're open for discussion then of the information that you've received. Pally.
Jacqueline, just for a point of information, you mentioned that our plans are being submitted to the regional NHS England. Your exact words were for approval and review. That threw up a question. So what is their role in commissioning, and can they say, oh no, that doesn't seem right, and do we have to go back to them and say this is what's happening, and what's their power role here?
So, I mean, we're part of a single NHS, aren't we, in a wider infrastructure, and certainly within the NHS England remit to oversee ICBs in the pursuance of their statutory duties.
At regional level?
Well, the region is not a statutory body in itself. It's merely, if you like, a local outpost of NHS England. It's part of the wider organisations. It's not a separate part. It is literally a department of NHS England, so acting on behalf of the NHS England executive. So they do have the power to review our plans and ultimately let us know whether they're approved or whether they're calling them in for further review. And ultimately there are regulatory powers they can exercise if they feel our plans are not in keeping with the expectations of ICBs. I mean, we wouldn't anticipate that we'd get there, Pally. And clearly the measures will be, that they'll be focused on, will be those set out in the planning guidance. Are we living within our financial allocation? Are we meeting the asks of the national planning guidance?
Tom Hall.
Yeah, thank you so much for the update, Jacqueline. I guess it kind of builds on Pally's comment really about kind of national requirements versus local need and kind of the needs within our population. Do you get a sense of how the planning process might evolve in the context of the 10-year plan to be kind of more focused on population health, local priorities, and then how we might commission for outcomes rather than, because it seems quite activity based and quite target driven rather than outcomes in which we think our population should be aspiring to.
Thanks, Tom. I think that is a fair reflection, and of course part of the challenge is that some of those things such as the waiting times and levels of activity are much more readily measurable at the moment than some of those broader outcomes. I mean, we do have the 10-year plan, as you know, and as David mentioned, there is a slight, some movement towards that in terms of there's a higher growth allocation for community services in the allocations received last week than there is for any other area. And I think the requirement for us to do a comprehensive population health needs assessment by March is another key plank, which will sort of drive the focus on delivery of outcomes and a more kind of community personalised proactive model of care that we all recognise and aspire to. I think we should also recognise, I think, that things like the waiting times are really important to our public, and that is why they remain a key focus. People are very concerned about how long they have to wait, and we know that that's a key focus in the plan as a result.
Mike Smith.
And David, you mentioned that there is a portion of money set aside for left shift, though it's subject to affordability, which causes some concern. We've talked in the past about the challenges of trying to disaggregate what money is being spent on prevention versus reaction to health events. I just wonder whether we should try and keep our eye on the ball as to how much of that pot is being kept aside for left shift versus how much we've had to say is unaffordable, just so that we're being transparent about where we're at in that regard.
Yeah, absolutely. We can do that, Mike, and we will do. And the reason I say subject to affordability is that is basically what NHS England will say to us: you've got to have an affordable plan, and some of our priorities that we have to achieve are absolutely tantamount in terms of providing services for patients. So in an ideal, we'll do everything, wouldn't we, in the 10-year plan in year one. But I think your point about tracking how much we're able to invest into left shift. You remember last year we had a specific fund, so I think being able to track that over time is really important for everybody.
David Stout.
Thank you, Chair. David, when I saw the slides, Jacqueline, when I saw your slides, I was slightly taken aback at the lowness of the cost uplift factor of 2.03%. I mean, bear in mind, NHS inflation usually trumps general inflation. I don't think we've got down to 2.2% yet in general inflation. So is this heroic? Choose our words carefully. I mean, is there a risk that, in fact, this will not be enough at 2.03%?
So it's been set at 2.03%, less than 2% productivity efficiency target, yeah. So it's effectively flat cash. What NHS England have shared with us, that is based on a pay award, I believe, of 2%. Now, I believe the government has actually recommended a higher rate than that. And what NHS England have said is, once that's agreed, the cost uplift will increase and more funding will come to ICBs to distribute to providers as well. So it's a planning assumption at this moment in time because the figure hasn't actually been agreed yet. And in terms of NHS inflation compared to CPI, yes, sometimes it can be higher. So I think that it's going to be challenging to deliver, especially at provider level, because they'll feel the pressures on inflation on the cost of the delivering services, especially when there's an assumption there'll be a 2% efficiency in there.
Yeah. Can I ask another question? I mean, I know these are just headline numbers, but bear in mind, on an earlier presentation, David, you emphasised the need to get back into recurrent financial balance as an ICB, whatever that means, whatever recurrent financial balance actually means. And I just assume that, therefore, you'll be going through, say, the Finance and Performance Committee later down the process to explain the mix of recurrent and non-recurrent for the next couple of years, which will get us to where we need to be.
Yeah, absolutely. So there'll be more detail will come to the Finance Committee in terms of what are the numbers looking like and how does the underlying deficit of the ICB change over time. Now, in an ideal world, we wouldn't have one. And in an ideal world as well, we'd look to limit that quite quickly. What I would say, though, is that there's value in planning for having a bit of non-recurrent efficiencies and having a slight forecasting a slight overspend, if you like, on a recurrent basis, because the danger is you're almost too prudent in your financial planning, and at the end of the year you're left with a sum of money that you haven't actually utilised because of slippage and things like that. So we've always committed to the system to put out all the money we can into the system as early as possible, so people know what they've got to play with to avoid this money coming out near the end of the year and it's too late to use it wisely. So it's a balancing act. So I don't know if we're necessarily going to get to zero. We'd love to by the end of, say, year 3, but we should be moving at least in the right direction to a manageable level.
That's fine, David. Thank you.
Sam.
Thank you. Probably just a few things to add, and apologies if I've missed these, they've been picked up. I thought the bit of work that we'd undertaken looking at our financial allocation over recent years, working with other ICBs, has been particularly helpful in terms of the allocation, and obviously we're not having convergence applied in the same way we have done for the first 3 years of the ICB. So that's a benefit, which is helpful. I mentioned this earlier, but I do think we need to formally record it on our BAF, which is obviously the organisational change that we're going through. So it's a really good problem to have. As I said, it's a positive that we've got the 3-year allocation coming, but it is a significant amount of work, and tomorrow we potentially put a number of our key people at risk of redundancy. So they'll be going through this organisational change period, whilst obviously continuing to keep the show on the road from a planning perspective. And I think that's a risk that obviously all of the steps that we're taking to mitigate that risk. I think the question around is it heroic on the 2%, I would probably say elements of it are, and I think we need to be clear about that. So I think we talk quite a lot obviously about the impact and the flow through to NHS organisations, but half of our money is spent outside of the NHS. And when you look at the cost of living increases, inflationary increases, if you look at our rising cost of continuing healthcare, these pressures are very real and significant. And I think that takes us probably slightly back to the commissioning intentions, and so far as I think as we iterate through the planning process and make the work up to our final submission in March, I think as a board we may have some strategic choices to make around ongoing investment and also potential further investment as well. We know this financial year we've disinvested quite significantly in a number of schemes, and we'll inevitably, I think, have to do that going forward as well as we cut our cloth accordingly. And certainly the message out across NHS organisations is, irrespective of the 2% uplift, actually we're in a sort of a diminishing cash position here when you look at the increasing costs of workforce as well. So I think it's just helpful for us as a board to really understand that. And I know that's certainly the situation that businesses are facing. It's the situation that our local authority partners are facing, and we are absolutely no different from an NHS perspective.
No other comments or questions? We move on then. Thank you, Jacqueline and David. Jacqueline, it's you again now on the strategic approach to clinical services.
Thank you, Chair. So I'm pleased to introduce this strategic approach to clinical services framework and recommend it to the board for approval. The framework sets out a systematic approach to developing sustainable clinical services, particularly in our hospital sector, both our acute and our mental health sector, and also has an initial focus on our most vulnerable and fragile services. It's been developed under the leadership of the Provider Collaborative, which of course is chaired by our colleague board member Ken, and I'm sure he may want to make some comments about the process that we've been through, but also we've worked very closely through its development process as ICB members, particularly myself and Neil have been part of the process throughout. As is clear in the framework, there will be roles for both commissioners and providers as the framework shapes out, and that's why one of the recommendations is to note that there will be, it will in future shape part of our commissioning programme too. In terms of the process to develop the framework, there's been a lot of clinical involvement and workshops. There's been patient involvement, voluntary sector involvement, and also a really thorough parsing of insight data, both patient quality data, but also finance activity type data as well. I would remind the board that we did have a chance to have this discussed in a bit more detail at a development session a few weeks ago, and I hope you can see that the feedback from that session has been incorporated into the final report. So I think it's a helpful sort of structured and robust approach that will allow us to do work across providers on service challenges, particularly focused on service challenges that span more than one organisation, and where collaboration can really make the difference to find a sustainable path for those services in the future. I think it's well aligned to the medium-term planning round, and will be useful. Obviously, the proof of the pudding will be in the eating, but we're recommending that we get this approved. I think endorsement of the ICB board is seen as critical to the credibility of the framework. Look forward to seeing it in action. Obviously, we'll continue to develop it with our partners going forward. So the recommendations are that we approve the framework today, that we note that alignment to the broader strategic planning arrangements, and also note the need for the ICB to stay involved in the future, and recognise that there may be commissioning implications as an output of some of the service reviews that will be done under the auspices of the framework. Thank you, Chair.
Well, we did, as you remember, unpack this very thoroughly at the development event, and as Jacqueline said, quite some further ideas came which have been incorporated. Are you happy to approve this, or do you want to have further discussion? Okay, yeah. And then I omitted to ask you whether you would approve the strategic commissioning intentions on the previous item. Oh, good, okay. Thank you. We're on to, there isn't any other business because we asked that at the beginning. Questions from the public. Our board secretary, Deb Cornell, will address that.
Yeah, thank you, Chair. Just to confirm, we have received 2 further questions from members of the public. However, as they don't relate specifically to the agenda items today, we will be responding to those separately to ensure they have a full response.
Thank you. Good. Well, I think I can't see anything else on the agenda. So we're finished, and thank you everybody for coming. And as we won't be convening in this way again before Christmas, then best wishes to everybody for Christmas, and we look forward to seeing you in the new year, when we'll be right in the middle of a major piece of work, I think, in finishing the transition and then starting to work in our new role as Strategic Commissioner. So, thank you.